today, by focusing on obstetric violence, EATG center the long and enduring history of biological reproduction as a site of social violence. And in doing so, EATG wants to highlight how obstetric violence has reflected and amplified many different forms of social and political discrimination, oppression, and exclusion. And that's why I'm very, very happy to introduce you to Medea Khmelidze from the Eurasian Women's Network on AIDS. She will talk to us about the scale of obstetric violence against women living with HIV in Eastern Europe and Central Asia. I leave the floor to Medea to first introduce herself. Thank you.
Thank you so much. Thank you. I hope you can hear me well. My sound is clear. Again, thank you so much for Nicoletta and the whole EATG team. I'm really grateful that you gave me the possibility to be together with you.
I cannot hear you.
I got back. I just thanking to all the participants for being with us, because I know how many regional meetings are happening right now today. So thanks a lot that you decided to join us, support us, and listen to whatever information we're going to share, because this kind of shared information and the sharing of the experiences is really, really important, especially when it comes to women perspective, women rights, everything related to reproductive health for women living with HIV and those who might be affected. So generally, if you let me, I will share my screen before I start speaking about myself. And it was kind of really funny that when I shared the picture, I've noticed how angry I am on the picture. But yeah, so with the situation that is happening throughout the world and how that all affects women and how it all affects our reproductive health and our choices, I don't think that picture could have been that, pleasant with a smile. Yeah, definitely the things we're going to discuss, it would be sometimes even very hard to listen. We have this generated report, and when we were drafting this report, I just realized together our team of EWNA that we used at several parts, we used the kind of the disclaimer that it is really sensitive and it's might be traumatizing to read some of the parts. So yes, that's something I would like to mention in the beginning. Whenever you hear some things, we all have different experiences, and sorry if that causes this traumas, again, going through our experiences, but I would like to say that we are together. These experiences can be alike across the region, and it's us again that we can support one another and give the back, and that's what makes us stronger. I mean, identifying, understanding the problems and try to solve them. That approach definitely makes all us stronger. As I said, I represent Eurasian Women Network on AIDS, and somehow I can't change the slide. Can the slide move? Just a second. Is the slide changed? I don't think it is. At least I see the same slide. So I represent Eurasian Women Network on AIDS. Let me restart this presentation so that it gives me the possibility to switch it. Yes, Eurasian Women Network on AIDS, it's a very unique in its term. When I joined it, it happened a year ago already. I realized how much this organization gave me within a year. I've collaborated with them for about 15 years myself. My organization started functioning in 2015, but the team I know even before. And this is exquisite team that definitely brings all the expertise that can help build the capacity of the community and bring all these important experiences of women living with HIV, different experiences, and try to solve them through sisterhood, through support, through empowerment. And for that, I'm really grateful that I have the opportunity to work with them and now stand and represent them as an executive director. Can I ask you to help me to switching the slides, please? Because I don't think I can. Oh, now it works. One of the strategic areas that we work is obstetric, generally is the reproductive health and rights. And we do different level working in order to increase access to sexual and reproductive health and rights services for every woman in Eastern Europe and Central Asia. That's the region we cover. And recently, we've had the very interesting process, the research, that targeted experiences relate to obstetric violence. Why I'll speak about it a bit later, but I just wanted to say about the very exquisite nature of this report and the process itself. By that, let me discuss briefly about the structure. So I'll try to cut whole presentation into 3 parts. First, we will discuss why this research and why the community-led perspective, why it's important. And after that, we'll do a pause and maybe think your opinion about that, maybe some of the experiences you have, because I see many of the people who participate, when I had the glance at the participants, they do understand the process, and some of them were part of the process on the national level, on the regional level. After that, we will go directly to the outcomes of this research. We'll pause a bit and maybe think about this intersectionality and how these outcomes somehow give us better understanding on different medical and social variables affecting these experiences. And after that, as a third part, we'll kind of do the summary and think about some of the recommendations we've drafted. And it would be really nice to hear the feedback from your side as well. So we're very open discussing whatever interests you might have. And there is such a vast topic. And if I see the specific parts are most of interest of the group, I'll try to be more detailed and more specific about the part based on the audience interests. Okay, about the research, the first of all, why this research, right? Nicoletta actually had such a great introduction about the perspective women have and their experiences they have when it comes to sexual and reproductive health and rights. And honestly, when this idea of the research has been developed, I understood how much the process itself was enriching in terms of understanding how obstetric violence as such fits in general reproductive justice framework, but at the same time, what makes it very specific. And Nicoletta also gave a very good and very clear definition what the obstetric violence is. So simply saying it's something that would not have happened, not a person not having experience of getting pregnant in general. But there is another dimension in this research. So not only we wanted to study the experiences of the pregnancy, rather that was the experiences of the pregnancy among women who lived with HIV at the process of the pregnancy and them knowing their status during the pregnancy. So that was the really important part, and because as us being the community-led network, uniting 14 countries, like 40 members, all of them representing their local communities on the level of NGOs or initiative groups. we've been discussing this part as very important at many levels, and there were some initiatives, but I would like to mention the Ukrainian experience. On one of the first research was done in Ukraine, and we realized the scale of the problem and the intersectionality to other medical and social variables. We've decided that that was the time to have the evidence, whatever we as a community have been discussing for so many years, and the problems and the case studies we've been dealing with throughout the years. So that was the motivatory factor to us to go through and see, so, okay, what happens? And it was done through a specific methodology, which I'll speak about later. And there were so many local, regional, and international experts who helped drafting us this very kind of simple but very specific questionnaire. Regarding the methodology itself, you see that it covered 365 women from 13 countries, including Eastern Europe, South Caucasus, and Central Europe. But taken into account, and you see this scale and number distribution on the slide right now, take into account that this participant distribution from the countries are different, we can't say that the outcomes are representative on the national level. But for sure, what we can say is that it shows the trends of different types of the violence and their influence on the women living with HIV in the region. So these tendencies and the trends are really important to take into account, right? So again, before I move to the kind of portfolio of people who might be covered through the research, I would like to say a few words regarding why specifically community-led initiative. Because when we do the researches and when we do the assessments and we do it through the support of the national coordinators and community representatives from each country or the subgroup, or it was really intersectional, not only we generate and mobilize the group, but we also bring the knowledge. So it's a process. Outcomes are really important, but how we build our own capacity through this type of the research, how we give the possibility for the representatives to understand what's the research, how to work with different types of the methodologies, how to mobilize people, involve them into the, drafting the methodology. And it happened at every step. So it was not something that some group of experts developed the methodology and we disseminated it with the, the communities. No, the community representatives were involved to review of the existing methodology, then drafting the questions. Then we piloted the questions. We translated it every language that of the countries you see. There were different languages spoken on the local level. We piloted them and got the feedback, and only after that we pushed it throughout the region. So for me and the team, it was a very enriching process by itself, how we deal with specific questions, how we adapt specific questions. It already showed some of the, wide spectrum of experiences many people had, and they were contributing by their own experience or based experience of somehow participating a similar type of the researches on the local level. And it was really enriching. I mean, it took a lot of time though, but it was a very constructive process and very enriching. It was capacity building, us understanding some of the topics better by itself, right? So not only bringing the perspective or driving for outcomes. And that's why we usually say that when it comes to community-led monitoring and community-led processes, it's really important not to lose this component, because this is one of the very strong tools of generating information, but at the same time building capacities. This is regarding the methodology. This is regarding somehow the overview, why this type of the topic dealt, why now specifically. at that moment, just to say again, if I did not put much focus on that, and would be part of the criteria as well, getting back to that, we covered women pregnant who was pregnant or delivered within the last 5 years. So that was also one of the criteria. So some of the outcomes were shocking to me. I'm sorry saying that, because we think that, okay, we've been working so much time in this field, we know everything, and like having expectations, but some of them were shocking because during the outcome, I'll pay focus on that. Sometimes we think some of the types of the violations happened like 20 years ago. It doesn't happen now, but unfortunately we realized not the case all the time. So I think it was already a lot for digestion. I would like to pause here and ask, maybe you have any questions up to now, or maybe if any of you have been somehow engaged in similar type of the research, just a brief comment if you'd like to share or ask about importance of the community-driven initiative, community-driven research. Anyone who wants to jump in for now? You can unmute your mic and contribute to the discussion. Of course, it's not mandatory if you feel like talking at that point. If not, that's also fine. We'll keep this discussion as well by the end, for the end of the presentation. So I don't see any hands. No one unmuted the mic, so I think I can continue, right?
Yes,
maybe
please.
there would be more discussions when we jump to the specific outcomes of the research. So on this slide, actually, you can see the distribution of the respondents according to the age, and you can see the highest number still comes on the age group 35 to 44, but it's also interesting, this age group 18-24. So there was one of the criteria actually, if that the person should have been already 18 during, should have been 18 during this experience. Education. As you can see, the most of women involved throughout the research had secondary or secondary technical education, and only very few had no formal education at all. Again, usually it might be interesting, maybe that cross check sometimes this, stereotypical thinking that the problems happen only with low education, or the group that specifically represent having very hard socioeconomic situation. Sometimes we see not the case, right? Employment, again, very interesting, and definitely expected that most of the women at that moment was on maternity leave, because some of the experiences of the pregnancy and delivery was at the point. And what I would like to mention is that, okay, getting back, is it was not only about delivery, right? As Nicoletta also said, it was about experience of the pregnancy and / delivery and postnatal care. So we had some respondents that like went through the pregnancy, but the pregnancy did not end up with the delivery. So that was also an interesting thing. About the relationship status, you hear that most of them were in the relationship at that moment. As for the financial condition, you can see that, still with the very good level of this education such, here, the most of them, you see, explain that, okay, maybe employed, but not very well off according to their personal vision and the personal feeling. Children, as I said, there were very very few who had no children, because we understand not every pregnancy ends up with children. And you see that most of the respondents, like 38, had 2 children, and there were less with 3 and 31% with 4 or more children. Okay, this is one of the most interesting parts of this presentation, if you ask me, and it was something we really tried to make a lot of use of, because we all understand women living with HIV. It's not a homogeneous group, right? So there are individuals with various experiences, and yeah, not to make it as intersectional as possible, we ask the questions like based on your understanding, which is the group you belong to. And it was really interesting that some women, knowing who participated, could have attributed themselves to various groups. But for us, it was important however they felt, I mean, which was the group that was the dominant for their identity. And you could see the distribution, most of them, none of them mentioned. But another group coming was women who experienced domestic violence, unfortunately, 23%. And another big group, also women kind of having an experience of the substance use. Okay, now we'll speak a bit of their experiences of receiving health services. Good thing was that most of the women who participated in the research, like 66%, if you see, contacted the medical facilities 5 or more times. But it was still very alarming that there were only 1 or twice visit for 12% and 3 or 4 times visit for 18%, but there were 4% of our respondents who never contacted a medical facility and already end up there for the labor. So that shows us again that whenever we think that the healthcare goes and takes the fast steps for the development, and we'll speak about the social justice, accessibility, availability, affordability, unfortunately, this equality and equity systems does not work the same for everyone. Type of the facility. Yes, so basically the big part was public hospitals. But it was very interesting aspect of it when in some of the countries to achieve the better quality and maybe affordability as well for the services, in the, you see the other, right, the small part, 3.50, there was kind of the mixture, and depending on the most affordable model, some of them start in the public hospitals but had the delivery in the private hospital, but sometimes it worked vice versa. So there was a very interesting observation. Sometimes women understand better, so what's the system, and do not only go to one type of the facility, rather do the mixture for the best and more efficient and quality care. Who paid? Yeah, 46% it was out-of-pocket payment, right? And it was either themselves, I mean, women, or support from the family budget. 42% was covered by the state insurance, 11 from various sources, and very little from covered by the private insurance, right? So when the private insurance, I assume, is some kind in the part where it's covered by the state, and state insurance can be the state subsidies, but in the private insurance that could have been the employment provided insurances. Satisfaction with the services. Yeah, unfortunately, again, yeah, this level of the satisfaction, I mean, the high level of the satisfaction, not that much, only 11% who said they were very satisfied, while 7% saying extremely dissatisfied, and there are some in between. It was kind of the person based on their subjective approach, okay. Now about the violence itself, this tracks the outcomes regarding the violence. Okay, interesting fact that the highest named violation related to psychological violence. When it comes to psychological violence, according to different methodological guides, we split them into, we kind of separately deal with the verbal abuse and psychological abuse, knowing that verbal abuse is a part of the psychological abuse. But that was also the feedback from the community saying that you have no idea how verbal abuse by itself can go into different directions. So we thought it would be interesting to pay separate attention to that. That's why it's like split. Breach of the confidentiality is still an issue, and we'll speak about it later. Denial to the medical services, unfortunately, 46%. Physical violence and unconsented medical procedure, that was 26% as a ratio. Now, as I said, verbal abuse, humiliation, accusation, insult, yelling, threats. Now, we all understand why verbal abuse separately, because by itself, it was really interesting to observe that layers of this type of the abuse. And you see that humiliation was the highest, 33%. While psychological abuse, we could pay attention to the isolation related to the status and ignoring requesting for help, which was 32%. Physical violence, again, really, really tough to even speak about that, right? Rough handling, 27%. Forcing to take a certain position for childbirth, 9%. Pushing the fetus out during the contraction, 7%. Roughly spreading the legs and even slapping. There was less, but still, if you ask me, even 4% and 2% are really rough for that type of the violence. Unconsented medical procedure. So by that, just let me give you a brief definition. Unconsented medical procedure is not something forced, rather than when you do something without explaining and without very certain informed consent, right? So these had been done without preliminary consultation, information, and consent-based initiation. 10% C-section, like using injections or vaginal tablets to induce labor, 5%, amniotropy, 5%, epistomy, 3%. Well, it's unfortunately, I'm not thinking if I know the simplified terms. When you help amniotomies to helping the pour the waters in like a simple language, not in the language, the medical language. Yes, and yeah, I would like to pay your attention to surgical sterilization. It was 4 cases only. But that was, personally to me, that was shocking, because surgical sterilization without informed consent, it's a criminalized act. And I was thinking that that's something we usually, read and the textbooks that happened in lots of cases, right? In Romania, getting back from 80s, right? And sometimes you have this understanding, okay, that happened, and that does not happen. But unfortunately, we still have 4 cases out of 364 who were sterilized after the delivery without their consent. Don't want to name the countries, but yeah, still happened. Breach of the confidentiality is still a huge issue, especially when it comes to sharing the information to unauthorized third parties within the facility to other healthcare providers. 90% it was in case of the family members, and 5% to the sexual partners of those women. Interesting part, I would like to pause on that. Denial to the medical services. Pain relief and management was somehow, expected when we were discussing some of the options. Also postnatal complication management, as well as the breastfeeding support. But what I personally did not expect, it was that high number to refusal or not being able to find the right support for the abortion care. And I would like to say a few words about this, how abortion stigma works in terms of women living with HIV, intersecting with their status and intersecting with the experiences that some of the women living with HIV are usually forced into abortion. So you to understand, if the community experiences intersectional stigma because of living with HIV, because of being women, first of all, then women in our region, then women who live with HIV have experience of the drug use. Usually their experiences, the spoken one, is that they are marked as, sorry for the word, like I'm citing now, not good enough women to have children. And because of that, within the community, we somehow block this possibility of discussing abortion care and those women needing abortion care, even the ones who have this experience or have the problems of searching abortion, we usually rarely discuss it within the community. And that's something to be taken into account. And there was another initiative based on that within this network, we started doing more on opening discussion about accessibility to abortion services, or quality abortion services that takes into account needs of women living with HIV. Now, who was the violator in these terms? Midwives and the nurses, physicians, both took 45%, nursing assistants, head of departments, administrative and technical staff. So under administrative staff, where it differs from the technical staff, those who also arranged the first-hand accessibility to the services. So administrative staff, one who actually is the middle chain that helps you to get to the physician. Discrimination factor. So what was the reason? And I think that was a very interesting to observe. Of course, the leading reason was HIV status itself. And the second one, socioeconomic status. And when we cross-check the satisfaction level, usually those women who mark that they do well financially, they were more satisfied with the service. So you to understand how these two determinants somehow correlate to one another. Yes, HIV status is the one thing that brings the discrimination, but it's usually attached with the socioeconomic status, because the women who do well financially but live with HIV, those usually have less problems. I can't say that they don't fully, because you can see there's a difference, but these two intersecting variables are really interesting to look at through one prism. Age as well. I might be citing some of women who were called old women during the delivery and saying that, okay, anyways, I'm sorry for mentioning that. I'm again citing, and sorry for that once more, like with your status and with your age, so you're probably not gonna live longer, so why do you put this child under this circumstances? And that very humiliating, threatening, and very unethical comments that these women unfortunately had experienced to hear. So what happens when this type of the circumstances pop out? Do they report, and who are the people who usually these women report? You can see the highest percentage goes to clinic management, And it's very good that some women actually know that they have rights and they reflect on this type of the violences right away. Family and friends, and the 15% mentioned public or human rights organizations and defenders, but there was another one. I think I didn't put it on the slide, but I would like to share this observation that the outcome, so what happened after? Do they feel that the rights were protected, and does something happen comforting them? Though there was less number of women referring to human rights organizations, but the outcome was as same as when they refer to the clinic management. So this is again showing how important to have these community-led initiatives and work in line with human rights defenders when such circumstances come out. Influence on well-being. So the question was how this experiences generally affected your well-being, and you say that it's like moderate effect, mild effect, no effect, 14%. But you know, 14% actually said severe effect. Under 2, which is other, I would also add it to their severe effect, because they're citing some of the women saying that after that they never ever went to the facility again. The trauma was that big. And that also links to what I want to share as a second slide, influence on accessibility. And yeah, you can still see that 5% say, I have completely stopped seeking sexual, reproductive, and maternal healthcare services. And 30% saying, I start avoiding certain healthcare providers or facilities, which is something need to be taken into account. Again, community support, that was the question, the final question. So what was the type of the support you received from civil society organizations? And that lets me think that still there are number of women, unfortunately, are not targeted nor tracked by this type of support, 23%. But I was very happy to see the opportunity that at least those women participated in the research. And it was really interesting to me how we disseminated information about the research. They were not separately asked how they know about the research, but it was very interesting to observe that, again, this community mobilization and their working together with the healthcare facilities, because they also helped us disseminating this information, somehow we managed to track people who are not in the map of the beneficiaries that get support from civil society organizations. And unfortunately, 10% as well said that, yeah, not only they do not get the services, but they do not actually know about the type of support. And this is something we need to keep in mind when planning the interventions further. Okay. Yeah, it's too many, I know, but I would like to again pause, and maybe this time you have the questions. Maybe you need some clarification from my side before we jump to the recommendation parts. Yeah, the floor is yours. You can just unmute your mic and ask the questions if you have some. Yeah, it's not mandatory again.
Thank you. I don't know. I don't know if there are. Thank you very, very much. This is kind of quite an eye opener in so many different ways, because it reminded me of the experience of women in Southern Europe in the early 80s. We were almost forced to be sterilized when we were diagnosed with HIV. So in a way, it's really sad that nothing has changed. Simply the narrative has moved to a different part of the world where women are very much still discriminalized. And I'm really moved by the data that you share with us. I really would like others to have the opportunity to ask questions, but if no one else want to say anything, I really would like to know a little bit more, if it's possible, about this, when you were sharing information about physical and psychological violence, did women also spoke more extensively about eventually the support they could get or they got after the experience of physical violence in particular?
Thank you so much. Very interesting question. When we had this preliminary discussion, I've mentioned that actually that was the research that gives the material for and the thinking for at least 10 other types of the researches. What I can say, there was this part of the methodology with open-ended questions. So it was, they could have commented, and some of they did. So I can share some of the tendencies, as I said, but it was not part of the focus. The only part of the methodology was after you reported, to whom you reported and what outcome did you achieve. So was there any type of the intervention after that? And it was up to, again, like half, I would say, saying that there was kind of the reaction after that. And interesting fact was like the split, that though many women reported to the clinic and the family members, and only 15% to NGOs, but those who reported it to NGOs, they had better support because of involving human rights defender representatives with that. I can share only that part. And some of the comments, that was an open-ended questions, but we didn't put it up here because it's qualitative.
Yes.
And we didn't attribute it to that part.
Thank you.
Medea, there is one question in the chat. It's from Olena Mikhailomichuk from Ukraine. The question is, does the data set include a country-level breakdown and allow for comparisons between respondents across different countries? Thank you.
Yes, so actually, the way the database is built, you can do so. I mean, you can track different answers according to the country level. But as I mentioned from the very beginning, the number of the different countries vary, and you couldn't take as something that could represent the tendencies for the whole community within the country. But with the database by itself, you can actually track. You can see specific tendencies more prominent for on the country level, but again, it won't be representative. If I answered your question.
Yes, thank you.
Okay, we can move on to the recommendations for discussion. Be mindful of time as well.
Thank you for much for these questions. And somehow I still stuck and can't move my slides. Have no idea why. Just a sec. Let me try to do it. Okay. Regarding the recommendation, actually, we put it for different level of the stakeholders. And I will try to again go through the slides, but it is stuck. Okay. Now it moves. I hope you can see this. Observations, and yes, here we are with the recommendation part. So it was addressed at different level. Legal and policy and practice reforms. Then it comes for the healthcare system improvements. And the second part for the community engagement and empowerment. And the slides are quite overloaded because we want it to be as specific as possible. But I would like to put my focus to some of the, specific aspects related to, first of all, helping on the national level our countries understanding and defining types of obstetric violence. So acknowledging these types of the violence is the first thing you might need to encounter with all the policymakers. And this is really important to understand. And somehow create a very friendly, anonymous, and safe reporting systems. And I really like the questions, especially focusing on, so where do we go and what we do, or how we just track those cases if not similar type of researches are done, right? So there should be some mechanism in place, depending on the country context, that helps those women share the stories and potentially get in time support when that type of support are needed. And what we call is maybe establishing patient ombudsmen or advocates within healthcare facilities, you know, to drive this the monitoring process and reporting process, ending up with the case studies to the right people, to the decision makers who can actually help. I would say a big bulk, what we discussed refers to how we actually provide regular professional development sessions on the patient rights, diversity, sensitivity, autonomy, and the social justice, integrity, which is honesty to the patient, and keeping the confidentiality. So these are professional development aspects for the healthcare. And I know within the region, partially the thematic areas are covered, but they never are intersecting with the rights of people living with HIV or any marginalized or criminalized population. So that should be something integrated within the educational curriculum if we want future doctors to be more friendly and to be more sensitive to the specific needs emerging. It is also important to address financial assistance barriers, understanding inadequate infrastructure and contribution to mistreatment for living with HIV. If again, you remember, for the question asked, what was the reason you think you've been discriminated? First, it was HIV status, and the second comes the financial and the social status, and there's something we need to pay attention to. And again, in one of the open-ended questions, it was not the focus of the research, but from the citing, what I remember, some of the women wrote that if we wanted to get better quality, we needed to pay out of pocket more. And that's something we need to keep in mind. And provide this emotional, psychological support, and not because like the pregnancy or anything related to pregnancy is more stressful for women living with HIV, rather than this intersectional stigma and how the system, how the infrastructure and these not only the infrastructure but the structural barriers affected them. Yeah, that's what causes traumas, and what causes stress, and that's something needs to be well dealt. And finally, community engagement. As I said previously, all the process, when it's led by the communities, when those women are supported by the community itself, which is less stigmatized, it is really important. So we need to equip those women with the tools. We need to build these capacities to empower them and to give this, you know, as a tool, the knowledge of their rights, to how to stand and support it whenever it's needed. And not only first themselves and maybe the peers afterwards. Yes, and also this approach of engaging with the service providers and supporting like social mechanisms of engaging community. It shows up being very efficient, and that's something that women think would work. And I would like to stress all these recommendations were drafted. Were drafted by together with the community leaders. We had 2 consecutive meetings after we analyzed the outcomes to come up with very specific recommendations that can be taken into account at many levels. Just you to understand, that's the vision, that's the community vision. That's what the women reiterated and urged us to share for the wide scale of the stakeholders. that's it, basically, from my side, what I wanted to share. Again, thank you so much for this. In the report, again, you could see some citing from the women about their emotional condition, these experiences. As I said, some of them was really hard to read and observe. But it gives us more energy to change the things, right? To change it works for the community. And I thank you so much for all these networks that actually listens to us and tries to like jointly work on any type of the very maybe small steps, but the steps that target women that are most in need. This is really important, and I'm very grateful. I really appreciate your attention and your being with us and give us this space to discuss this with such a large audience for the region. Thanks once again.
Thank you. And I'm just wondering if in the last few minutes remaining, if there is someone who wants to say something, ask a question, or even a comment before we close. I think it was such a powerful conversation. So I'm really, really grateful to you, Medea, but also to the 365 women that took part in this amazing piece of work. But, you know, let's remember that out of 365 women, 23% experienced domestic violence, far too many, and 2% were subjected to surgical sterilization, far too many. So we still have quite a lot to do. In fact, we have a lot to do, because this is not just a matter for women. This is a matter for everyone in our communities. And I think this piece of work has to be shared as often as is possible. We need to know more what is happening to women, so that as communities we're stronger and we can work together. We have 5 minutes, and I'd like to maybe ask you, Medea, if there is something that you haven't shared with us that you want to share before we close.
Just to say that the thing that everyone's kind of silent, when we started sharing these outcomes among one another, I mean, those women who were part of the mobilization, the same happened. I mean, it took us some time, even me, to, starting saying, okay, that happened to me as well. I didn't know that was part of, obstetric violence, even, with my knowledge. And yeah, it was really hard. And then not always spoke about when other meeting, we kind of when we want to speak about the recommendation, there was it looked like a therapy session. It took so much time, as digesting all the stuff and reminiscing the experiences and getting back. And yeah, and it does not only affect those living with HIV, right? So we might be affected in many ways, but yeah, there was something I also expected, because it's a lot to digest. And yeah, sometimes yeah, even if we wanted to speak about the recommendations, it took us hard time to get back to this, the working academic conversation. And yeah, again, thank you so much for giving us this opportunity. As you said, more we speak, more it is more easy to, it's easier to share this, the feeling around it, and maybe also strategizing how we deal with the violence, but also the traumas around it, to deal with our well-being and mental health in general. Yes.
Yeah, I think we need to start advocating for trauma-informed care for everyone who is living with HIV, but also for women, whether they're living with HIV or not, because most women have experience of trauma in their personal lives. Natalia has raised her hand.
Yes, Nicoletta, I didn't want to interrupt you. I just wanted to share that a couple of years ago, I was involved in the study on obstetric violence in Ukraine, and there are a lot of things which terrified me based on the findings of the study. For example, that all the respondents were denied certain obstetrics and gynecology service in a healthcare institution, and namely almost 27% of the respondents were denied giving birth due to their HIV positive status. And it's in Ukraine, in the heart of Europe. So I was deeply frustrated and terrified by these figures. And also, I think the chat, a lot of messages from the participants, not a lot of, but a couple of messages from the participants with deep gratitude to Medea for all the important and valuable information she shared, and for all great job you and the Eurasian Women's Network on AIDS have done in this regard.
If I have 1 more minute to add and to share, understanding this, complexity of the issue, the community leaders, I don't like the word, but let's use it here. After that, they gave this possibility, especially to those who were involved, getting back and if they would need any kind of support, the psychological support, or any redirecting to the sexual and reproductive health services, because there are parallel processes were going on, like boosting the information around the importance of this cancer screening initiative. So we try to do it holistically. The good outcome, one case I remember was that one of the women came to specific consultancy regarding the right to parenthood, and she was supported by the local lawyer, and she won the case. And she was discriminated. In fact, the family saying, okay, you living with HIV, if the status comes out, there is no way you would be appointed as a legal guardian for a child. And there was something for us after that. And another thing, I would really like to thank the team of EWNA, not only this representing staff or secretariat, but all the members who were involved there, because that's my personal feeling, but the level of my knowledge and in this increased a lot. I mean, I
think there are some connection issues.
Yes, maybe. I think our time is up. But again, I want to reiterate a big, massive thank you to all the 365 women who had the power within themselves to be part of this important piece of work. Also, a very big, massive thank you to Medea for facilitating this. Thank you to Apostolos. Thank you to Natalia. Big, massive thank you to Vladimir. His expertise in interpreting has been vital today, so everyone could hear what we were discussing. There is so much that we still need to do for women and with women, and this has to be the beginning, not the end of a conversation. And it's, for me personally, it's really shocking, because I was almost victim of obstetrical violence. It just happened that there was a blackout, so they didn't perform that on me. So this particular experience had kind of traumatized me for life, and it happened 40 odd years ago, and it's still with me. So I can only imagine how the 2% of women who had that experience and those who were near to having that experience could feel. Thank you very much. Let's keep the conversation going on this.